Okay, can start. So first presenter.
Alya will be presenting. Alya.
Okay.
I will be presenting.
Okay. Alya Shahira. Okay.
Doctor, can you see my slide?
Let me pin on it. Belum lagi.
Belum lagi.
Yeah.
Now?
Okay. I don't see it.
Yang lain boleh nampak? Macam mana?
Nampak
Ya.
yang
Nampak yang mana?
nampak yang web tu. Nampak Gmail.
Awak
Sekejap.
window. Share window.
Kita tekan share
You
apa?
need to share the slideshow. nak share slideshow.
Share slide. Tapi kat sini ada entire screen, window dengan Chrome tab je.
Ambil yang ni Chrome tab. Apa Alia buka guna apa? Yang
Ada? Window.
Dah buka dah kan? PowerPoint tu.
Oh, okay.
Okay.
Boleh nampak? Nampak ke?
Dah.
Yes, we can see now.
Ya.
Make it full screen.
Ada?
Make it full screen.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Alya Shahira. So today I present to you my case presentation. So for chief complaint, this patient, 6-month-old Malay boy with no non-medical illness presented to the emergency department of HTA with complaints of passing loose stool for 6 days and then passing bloody stool for 2 days prior to the admission.
Okay, we will stop here. So Aidan is 6 months. 6 months.
Yes.
So you said boy with no non-medical illness. Okay, that's good. Yeah.
Okay.
And complain of huge stool for 6 days. Okay. And then followed by passing bloody stool. So everyone is following here. So is this chronic disease or acute disease?
Pardon?
Is
I'm
it
sorry,
acute disease?
Doctor. Your voice seems not okay.
Voice kita ke?
Is it acute or chronic disease?
Acute.
Acute disease.
Presentation.
Yeah, acute presentation, likely acute disease. But we don't know, it may be the first presentation of chronic disease. For the child
Yes.
previously fine. So likely this is acute. Most of the areas are acute. So maybe likely this is acute. But we don't know, it may be the beginning of chronic disease. Maybe the beginning of chronic disease.
Yes.
So when we can say chronic diarrhea?
More than 14 days.
More than 14 days, very good. More than 14 days, then we can say chronic diarrhea. If less than 14 days, it is likely acute. Okay?
So he was apparently well until noticed by his mother to have loose stool 6 days prior to admission. So the stool was mushy-like consistency, and it corresponds to the Bristol stool type 6, and it was greenish and yellowish in color. The
Very
volume
good.
of
So look at the Bristol. Bristol stool is very important. So we can see 1, 2, 3, 4. So we should have 4. 4 is the good one. 4 is the good one. If you ask you to describe, you can see type 1 is hard pieces separated. Hard pieces separated. Type 2, hard pieces attached. Hard pieces attached. Type 3 is sausage. Sausage shape, not cracked surface. The surface is cracked. Type 4, the best, which is the normal stool, the sausage shape with smooth surface. Type 5, soft pieces separated. Soft pieces separated. Type 6, output is nothing, type 2 or 3. Okay?
Okay. So the volume of stool was not mentioned, but it is said to be same amount in each change of diapers, and it was associated with a minimal amount of mucus and increase in frequency of bowel output. So the usual bowel output for this child is 1 times per day. However, during the episode, it increased to 8 to 10 times per day, and each episode had about same amount of volume and same characteristic. And during this time, there's no blood, no foul smelling. About the aggravating or relieving was not mentioned. And then 2 days prior to admission, after the 6th day of loose stool, the bowel the frequency of bowel output reduced from 8 to 10 times per day to 3 to 4 times per day. However, this time it was bloody stool. So the characteristic and volume was same as previously, but it was the stool mixed with blood in each bowel output. So the mother explained is as streaks of bright red blood mixing with stool. However, she was unsure about the volume of blood, but said to be minimal, and also still had the minimal amount of mucus, but no foul smelling. So otherwise, the mother denied any history of fever, blood clots or jelly-like stools, any vomiting, abdominal distension, inconsolable cry, pre-anal redness or tear. There's no changes in urine or urinary habit, no symptoms of bleeding tendency like gum bleeding or bruises. There's also no rashes, mouth ulcers, skin changes, eye problems, any joint swelling or redness, loss of appetite, loss of weight. And also there's no history of trauma prior to the incident, no anemic symptom like pain, rapid breathing, fatigue, cold peripheries, and no dehydration symptom like sunken eye, dry lips, reduced thirst or urine. And also this was the first episode, the child having this condition. There's no previous history of same illness, and throughout this illness, the child is still able to tolerate food, drinks, and still active as usual. So on further questioning, he was recently started weaning since 2 weeks before the admission. So he was given rice porridge with blended fish or chicken and also vegetables. No change of other meals since then and no new formula made. So regarding the food hygiene, mother used boiled water in preparing both porridge and formula meat. However, she only immersed the meat bottles in hot water only once in a month. So the last immersion was 1 month before the admission. Otherwise, there's no history of outside food intake, no history of recent travelling, water activity, sick contact or same illness in the family. And the house was said to have a clean and safe water supply and good sewage disposal. So, in view of this unresolved loose stool with blood, the mother brought him to the hospital to seek further treatment. So, otherwise, the systemic review was unremarkable. So, this child had no non-medical illnesses, no past surgical history. He was not on any medication that can induce diarrhea like antibiotics, no non-drug or food allergy yet. For antenatal history, it was uneventful. He was delivered via spontaneous vaginal delivery at 39 weeks POA. The birth weight was normal, 3 to 3.5 kilogram. And there's no other complication and no NICU admission. So for nutritional history, he was exclusive breastfed only for 1 month and then introduced with formula milk due to mother had difficulty in expressing the milk.
Okay, stop here.
Okay.
Do you believe that?
Pardon?
Do you believe that mother has difficulty in expressing the milk?
I'm not sure.
This is the problem, huh? This is the
Yes.
problem. There is lack of education about breastfeeding. There is lack of education in the society. Please help your society to educate about breastfeeding. This child received only 1 month breastfeeding. That is dangerous. And his sickness is related. If you go and study the benefits of breast milk, it reduces the incidence of diarrhea and disease. and reduce the incidence of respiratory tract infection. So this side, having diarrheal disease, so breast milk is related. Because a lot of problems of the formula. Can someone pay open what is the WHO recommendation for breastfeeding?
I did it.
WHO recommendation for breastfeeding.
2 years.
Yes.
2 years.
That is louder. Okay, 2 years. Nur Afika said 2 years. Okay, if I ask you what is the recommendation, give me details. How long exclusive breastfeeding? Okay, Afika, how long exclusive breastfeeding? So the whole duration 2 years. Yes, that's correct. The whole duration of breastfeeding 2 years. Exclusive breastfeeding, how long?
6 months.
Exclusive
6 months.
months.
Yeah. If they ask you what is WHO recommendation, so your full answer would be exclusive breastfeeding for 6 months. Weaning at 6 months by introduction of other food, not formula. Weaning, introduce formula. Weaning means introduce other food and continue breastfeeding for 2 years. So this is WHO recommendation, and before WHO, it was mentioned in Quran. It was mentioned in Quran. So the problem now, many mothers, they don't give breastfeeding. Can you, from your experience, okay, forget about the books, your contact with the mothers, can anyone tell me the causes which make mothers stop breastfeeding? See in your life, you have seen many mothers stop breastfeeding. What were the causes?
Because lack of education regarding the breastfeeding.
Louder.
Like the first one, they have lack of information and education regarding breastfeeding for the first baby.
Lack of
Okay.
education, okay.
Wrong breastfeeding technique.
Okay,
Breastfeeding.
many mothers, yes. Okay, I tell you now, then you tell me how to educate the mother. If mother comes to you, say, I am working. So that my child will stay at home. So he needs formula. So what will be your advice?
She can express first and then start at the
Very good.
end.
Yes. Express. She can express. And especially now there are electric pumps. They are very easy. Last time manual pump is a bit difficult, but electric pump just connect to the electricity and connect to the breast, the milk will come out. Very easy. So we advise her to express. And how to give the milk to the baby after expression? How the caretaker will give the milk to the baby? Can we use the bottle? Can we use the bottle? No, we don't use the bottle. Be careful. Don't use the bottle. Use cup, spoon, or syringe. Don't use the bottle. Use cup or spoon or syringe. Why? Using the bottle will make nipple confusion for the baby. You see, the mechanism of taking is different and the bottle. So you see.
Sorry, Doctor. Can you repeat what you said just now? I cannot hear you.
Okay. You see, when we give expressed breast milk, we shouldn't use the bottle. We shouldn't use the bottle. Okay, if we use the bottle, nipple confusion will happen. Nipple confusion will happen. Why? Because of the baby. If the baby uses breastfeeding direct from the nipple, the mechanism is suckling. S-U-C-K-L-I-N-G. Suckling is forward, backward movement of the tongue. Forward, backward movement, forward, backward. If the baby uses the bottle, the mechanism is sucking. S-U-C-K-I-N-G. There is no L. Sucking is upward, downward movement of the tongue. Downward, which is more easy. So, what will happen to the baby? If the baby uses the bottle, then he will stop using the nipple because of nipple confusion. And we don't want that. We want the baby to stick to the nipple because maternal-child bonding. Maternal-child bonding. So that's why we use either the cup or the spoon or the syringe. Is it clear?
Yes, doctor.
Yes, doctor.
Yeah. Okay. So another question. If one mother comes to you, tell you that my milk is little, what's your advice? You can type the answer or you can turn on the speaker and speak. The microphone, I mean. If the mother say my milk is little, what's your advice?
Check the
Many
technique.
mothers now tell you, I don't have enough milk.
Check the
Yes.
technique.
Technique. Okay, you teach her the technique. Okay. How is the technique? Tell us what is the correct technique.
Sorry, doctor. I'm not.
Latching.
Latching. How latching? Explain latching. How latching?
We need to introduce the nipple into the baby belly.
How?
And then
Nipple?
and the baby must suck all the areolar part of the nipple, like the areolar part are into the baby's mouth.
Yeah, you need to touch the upper lip and the lower lip. Introduce the nipple, touch the upper lip and the lower lip. You need to touch upper lip and lower lip. After that, baby open the mouth. When the baby open the mouth, muscle. The nipple goes in. So you need to touch the upper lip and the lower lip. Okay, but many mothers, you teach them the correct technique, but then she tells you, my baby is still hungry. He doesn't get enough milk. I don't have enough milk. What's your advice?
Can we say that for a baby at early age is normal because their gut size is just like a neck size? So actually just enough for the baby. Just to reassure the mother.
Okay. You see, many mothers believe that they don't have enough milk, and the fact that any lady, when she become a mother, she will have enough milk. The problem is the psychological preparation and the stress of the work stress. Now many mothers are working, and you know, with work stress, what will happen when we have stress? What increase in our body? Catecholamines. Catecholamines increase. So catecholamines include adrenaline, noradrenaline, and dopamine. What dopamine do for prolactin? What is the action of dopamine on prolactin? Dopamine inhibits prolactin. Dopamine inhibits prolactin. So that's why if the mother has stress, the milk will not come out. The other thing, the psychological preparation, the mindset. Many mothers now, they keep in their mind that they are weak. They are weak. They don't have enough milk. So the false belief is a problem. So you need to support the mother. Tell her you must be confident. Say, I have the milk. Think in your baby. Take your baby. The milk will come out. The milk will come out. No mother without milk. All the mothers naturally have the enough milk. Only the psychological preparation, the mindset, and the belief. The other thing, the false belief also, many mothers, they stop feeding when they become pregnant. Many of them, when they become pregnant, they stop feeding. And unfortunately, the obstetricians themselves, they advise the mother to stop feeding. It's wrong. shouldn't stop feeding. She can feed during pregnancy. So if any lady asks you, I am pregnant and feeding, can I continue? Tell her, yes, yes, yes. Continue. Until when? Until you deliver the second baby. Then she will say, can I feed 2 babies? You say, yes, you can feed 2 babies, no problem. You must follow WHO recommendation. Must feed for 2 years. You can feed 2 babies. Now another thing. Many mothers believe that to give breastfeeding must eat a lot. And then they are worried that they will gain weight and lose their beauty. Many mothers believe that. So tell the lactating mother, number 1, you don't need to eat a lot. You eat normally. You eat normally, just drink liquids and believe in your baby, the milk will come out. You don't need to eat a lot. And about beauty, tell her, studies have shown that mothers who give breastfeeding maintain their beauty better than mothers who give formula feeding. So that's why we need to educate. We need to say that to the mothers to keep the breastfeeding for the babies. Breastfeeding is very important. Okay, clear?
Clear, Doctor.
Okay. If no questions about breastfeeding, you can continue.
Okay. So currently the child drinks about 4 to 5 ounces of formula milk per bottle and 6 to 8 times per day, and he already started weaning at 6 months, which was 2 weeks before admission, where he eats about 3 times per day rice porridge with blended chicken or fish and vegetable. So for development, he has normal developmental milestone appropriate for his age. So for gross motor, he able to sit with support roles, prone to supine, fine motor, able to hold toys, and already babbling and had strange anxiety. He had done immunization up to his age at KK Batu Hitam and no side effects noted from the vaccine. And for family history, he is the only child. The mother is 28 years old and father is 32 years old. Both had no non-medical illness. Otherwise, there's no history of bowel disease, any autoimmune disease, bleeding disorder, or any chronic disease in the families. And this was not a consanguineous marriage.
What history of bowel disease did you ask? What history of bowel disease?
I'm not sure. Maybe like I
Yeah, which bowel disease can cause diarrhea and bleeding and rectal bleeding?
IBD.
Inflammatory bowel
IBD, very good. Yes, okay.
So for social history, mother is a housewife while the father works as a lorry driver, a non-smoker. Monthly income is about RM2,000. They live together in a single-story house with adequate basic amenities and clean water supply at Taman Batu Hitam, Kuantan. So the nearest clinic was KK Batu Hitam, which was about 10 minutes from home, while HTA was 30 minutes from home, and they have their own transport, which is a car, to go to any healthcare facility. And the mother was the one that taking care of the child. So the physical examination, this was done at the day of admission. So he was
Before you do the examination, can you tell us the summary of the history?
summary. So this patient, Aidan, 6-month-old Malay boy with no non-medical illnesses, was presented to the emergency department of HDA with complaint of passing loose stool for 6 days and passing bloody stool for 2 days. On physical examination, the patient was not anemic or dehydrated. The abdominal examination and pre-anal area examination revealed normal finding. Other system was unremarkable.
Okay, usually after we finish this is the classical method which we learn. After we finish the history, we give summary for the history. After that, we go for physical examination. Then you can make another summary.
Okay.
Okay, fine. Physical examination.
So, on general examination, he was conscious and alert. He was not in respiratory distress or doesn't look
He
irritable.
was conscious and alert. What is the relation? Why you say he's conscious and alert?
Because if the patient is on severely dehydrated, patient might apa panggil? Might even unconscious.
Why become unconscious? Why?
Because patient develop shock.
Why should make the patient unconscious?
Because patient might develop shock from if severely dehydrated.
Yeah, why? Why should makes the patient drowsy? Why?
Why?
Imperfusion.
Perfusion too?
Brain.
Brain.
Yes. CNS perfusion. So CNS needs normal circulation. Yeah, needs normal circulation, normal perfusion. If the perfusion is reduced, the patient conscious level will change. So once I hear the patient conscious and alert, this is good news. Means the CNS still gets normal blood supply. Okay? He was not in respiratory distress or
Okay.
What type of respiratory distress you look for?
Pardon?
Is it tachypnea? Did you look for tachypnea?
Yes, tachypnea.
Why tachypnea? Why did you look for tachypnea?
Because in severe dehydration, it can also have tachypnea.
Why? Why severe dehydration makes the patient tachypnic?
Because of compensation from the body try to compensate for the low oxygen level.
Low level. But try to compensate, but not because of low oxygen level. Yes. See, when you have shock, means you have low tissue perfusion. What will happen to the metabolism when you have low perfusion? What will happen to the metabolism? Will be aerobic or anaerobic?
Anaerobic.
Anaerobic. What is the outproduct of anaerobic metabolism?
Lactic acid.
Lactic acid. Very good. How to wash out lactic acid?
Increase breathing rate.
Yes, increasing breathing rate. Because you see, we have fixed acids and volatile acids. When we have acidosis, so we can take out some acids. So one of the volatile acids is carbonic acid. Carbonic acid. So I have increased lactic acid, so I wash out carbonic acid. How to wash carbonic acid? By carbon dioxide. Because you know carbonic acid is CO2 plus water. So if I wash out CO2, so I reduce the acids. So that's the reason. Poor perfusion, anaerobic metabolism leads to metabolic acidosis. Is there any other cause for acidosis in diarrhea other than the anaerobic metabolism? Any other metabolism, any other mechanism can lead to acidosis?
Hypovolemic.
Yes.
Hypovolemic.
Yeah, this is hypovolemic. We have hypovolemia, we have poor perfusion, we have anaerobic metabolism. What else other than the hypovolemia? Is there anything lost in the stool which can cause metabolic acidosis?
Lost bicarb?
Yes, very good. Loss of bicarbonate. Loss of bicarbonate. This one can lead to metabolic acidosis. So that's why we look for respiratory distress, because the compensation for metabolic acidosis is by increasing respiratory rate. Very good. Okay, carry on.
So he looks pink. There's no pain. The hydration status was good with evidence no sunken eyes, moist mucous membrane, good skin turgor, and warm peripheries. The capillary.
How did you check the skin turgor? Can you tell us how did you check the skin turgor?
Usually we pinch at the pinch at
Pinch
the
where?
hand,
Abdomen.
abdomen. Okay.
Yes. In pediatrics, abdomen. So many times, many students, they tell me the hand. I think maybe adult medicine is different. Yeah. For us, for pediatric, it is anterior abdominal wall. Skin terger, anterior abdominal wall. That's the side for skin terger. No other side. Okay, carry on. You
Okay,
say CRT in 2 seconds. Can you show us how did you check CRT? Can you show us by the video? We want to see you. Show us how to check the CRT.
Okay.
Can I answer it?
Yes?
Usually, we check at the end of the nail bed. We press it here until it become white, and then release when you press it until it become white, and you release it, and it will become a second.
Okay,
The time taken from white to turn to the red.
Okay. I will do 2 maneuvers. Tell me which one is correct. Okay. This is one. Okay. And this is one. Which one is correct?
At the palm side. The palm.
Okay. Again, this is one. And this is one.
Oh.
Which one is correct?
Second one.
Second one. Very good. Why?
You put the finger higher than the heart.
Yes, very good. You see, we must be at level higher than the heart. Because if we have intact pump and good volume, so CRT will be normal in any position. Even you go high, once you have the good pump and you have the good volume, it will be normal. If you have hypovolemia, when you check it down below the heart, it may come out as normal because of the gravity, the venous stasis. So you may have misleading result. The patient may be hypovolemic, but you see it normal. So to be sure it is normal, take it up. Take it up. Yeah. Okay? Fine, carry on.
So his weight, his height, weight, and head circumference were within the normal centile. No bidet edema noted, no rashes or bruises. So there was a branula attached at the dorsum of left hand with no active infection. Otherwise, vital signs are normal.
Can you tell me about the 4 cardinal signs of peripheral perfusion? The 4 cardinal signs of peripheral perfusion. You mentioned here CRT. What are the other 3?
CRT.
We have 4 cardinal signs for peripheral perfusion. You want to check the perfusion of my periphery, you have 4 signs. So one of them is the CRT. Did you mention it? What are the other 3?
Temperature.
Temperature, very good.
The CCTVR. I remember in the morning CCTVR, the CRT, color, temperature, volume of the pulse, and
Okay, look like CCBR.
CCTVR.
Okay, C color and CCTV.
Color.
Here you.
I can't hear you. Can you speak again?
I remember in the morning, which is CCTVR.
Okay.
Okay, first C is CRT, and then the next C is color.
Very good.
Okay, T for temperature.
Very good.
And V and R for volume and the rate of the pulse.
Very good. Yes. So volume. So very good, very good. So color, CRT, temperature, and pulse volume. These are the 4 cardinal signs of peripheral perfusion. How to check the pulse rate in this child, 6 months old? What's the way of checking the pulse rate? Is it correct to check like this for 6 months?
We can check it at the dorsal artery.
No. What is the
Dorsal
pulse rate? The best way is to auscultate the heart. Auscultate the heart. You know, to check the pulse rate, the patient must be not moving. If you do it for me, okay, I don't move because I am adult. I understand the instructions, so I don't move, and you can calculate my pulse rate. Maybe 11 or 12 years old, the child also, he will not move. You can check. But 6 months, do you think he will be quiet and happy with you? He will keep moving. Keep moving. How to calculate? Impossible. Whatever experience do you have? You cannot. Yes, you can get the pulse volume. Because the volume, just 1 beat is enough to assess the volume. But for the rate, you cannot assess from here. For the rate, you put the child in the mother's lap and use your stethoscope. Put your stethoscope on the pericardium. That's the way we check the pulse rate. So be careful. See, simple things, but they make difference. And many students, they do them wrong in the exam because of the stress. So be careful. Be careful. And don't make mistakes in the simple, basic things. Carry on.
So on the abdominal examination, the abdomen was not distended and it was symmetrically with respiration, no visible peristalsis, visible mass, scars or any skin changes noted. The abdomen was soft and non-tender, no palpable organ, and the shifting dullness was negative. On auscultation, normal bowel sounds was heard, and on examination of the preanal area, there was no preanal redness, wound, tear or ulcer. However, rectal examination was not done. The
Why you
system
examine perianal area? Why?
to see if there is any fissures that can also causing bleeding, and also can be we also can see any complication from the frequent loose stool, so they can be rash, something like that.
Okay. If IBD, any complication you can see? IBD.
IBD, preanal,
Any ulceration?
You can see abscess, fistula, skin tag. These can be seen in Crohn's disease. Okay, carry on.
So for this part, so my provisional diagnosis for this is acute dysentery with mild dehydration. This was acute onset, and then mild dehydration because there's no dehydration symptom, and the type can be bacillary dysentery because of the poor hygiene of the bottle. So my different.
Okay, so in this case, do you think the cause is bacteria or virus?
I think the causes is bacterial.
Bacteria,
Because
very good.
viral like rota usually only cause watery diarrhea, doesn't cause bloody.
Exactly, very good. So when you see blood, it is less likely to be viral. It is likely to be bacteria. You see, I cannot judge 100%. I cannot say 100% not viral, but likely not viral. Likely not viral. Likely bacterial. The usual for the viral diarrhea, it will not cause blood. Viral diarrhea does not cause blood. So when we have blood, it is bacterial. So I open a question. Which viruses can cause diarrhea?
Rotavirus.
Rotavirus. Okay.
Norovirus.
What virus?
Norovirus. Adenovirus.
Adenovirus. Okay. So Rana, remember Rana. R-A-N-A. Rota, Adeno, Norwalk, Astro. Rota, Adeno, Norwalk, Astro. Rana. These are the viruses which can cause diarrhea. Okay. Now we have blood. So blood, likely it is bacterial. Which bacteria can cause bloody diarrhea?
Shigella,
Shigella, okay.
E. coli,
E. coli, which type? Type?
enterohemorrhagic type.
Yes, enterohemorrhagic E. coli. Very good. Enterohemorrhagic E. coli and 20% of enteroinvasive. Enterohemorrhagic E. coli causes certain syndrome characterized by anemia and thrombocytopenia and high urea. What is that syndrome?
HUS.
Yes, HUS. Very good. What's HUS?
Hemolytic uremic syndrome.
Hemolytic uremic syndrome. Very good. So, hemolytic uremic syndrome is caused by enterohemorrhagic E. coli. Which strain?
O157.
Yes.
H7.
H7. Very good. So, O157H7. What is the common food source for hemolytic uremic syndrome?
Vomit.
Burger. Very good. Burger is the common source. Burger is the common source. So again, you say Shigella, E. coli. What else? Another bacteria by S, also start by S.
Salmonella,
Another bacteria start by C.
Campylobacter,
Campylobacter. And another bacteria start by Y.
Yersinia,
Yersinia. Very good. Yersinia is common in Belgium. Belgium, you know Belgium country. Yersinia is common in Belgium. Belgium. Why Yersinia is common in Belgium? Because Yersinia comes from raw pork. And in Belgium, they eat raw pork. So that's why they have common Yersinia infection. Okay. What is the other differential diagnosis other than bacterial?
parasitic, maybe dysentery,
Amoeba. Okay. Amoeba. Okay. So in amoeba histolytica can cause. Don't say giardiasis. Huh? Giardiasis doesn't. Giardiasis doesn't cause blood. Giardiasis doesn't cause blood. And don't say cholera. Cholera doesn't cause blood. What does cholera cause?
Rice water store.
Rice water. Very good. Rice water. Okay. So maybe parasitic, maybe bacteria. Can it be another condition? You mentioned it before, which have perineal abscess and skin tag and fistula?
IBD,
Yes, IBD. Yeah. So IBD, we need to think in IBD if the condition is chronic. If the condition is chronic. But our patient now has acute condition. So I cannot say it is IBD unless patient doesn't respond. If the patient doesn't respond to antibiotic, still have persistent symptoms, then yes, I have to think in IBD. Is this age of the child common age for IBD?
No.
No, very good. What is the common age of IBD?
School age. 5. I'm not sure.
Israel? You see the interesting thing in IBD regarding the age, it is bimodal. Bimodal age. Bimodal. What is the meaning of bimodal? Means it has two groups. First group is 15 to 25. 15 to 25. Second group is 50 to 80. So first group is 15 to 25. Second group is 50 to 80. So you are in the first group. I am free. I am neither first group nor second group. I am free of risk of IBD. Okay, so 15 to 25, first group, second group, 50 to 80 by model age distribution. But few cases come. Does not mean that IBD doesn't come out of these. That is the common age. But it can come in my age. It can come in children younger than 15 years. Yeah, so it can come. I saw last time in University of Malaya, there are some children who are less than 15 years old and they have an inflammatory bowel disease. Okay? Carry on.
Okay, so my other provisional diagnosis, like mentioned previously, hemolytic uremic syndrome. And other than that, it can also caused by interception. The points for is he is male and 6 months old, which is the common age to have interception, and he had bloody stool. However, points again is there's no the recurrent jelly stool and no symptom of intestinal obstruction.
Okay.
And next is anal fissure. It can be due to the increased bowel frequency, and but the points again is there's a normal pre-anal area, and the next is diarrhea associated
Okay, so
hemolytic.
anal fissure, I am against anal fissure. Huh?
Yeah.
We know anal fissure comes from constipation. When the child has constipation, the stool, so it will cause the hard stool. Becomes very hard, it may become sharp, then causes the wound in the perianal area. We call it anal fissure. But the child has diarrhea, so unlikely to be anal fissure.
Okay, doctor.
Okay.
So next is like mentioned previously, IBD. But according to this age, it is called as very early onset IBD, which is less than, if I'm not mistaken, less than, I'm not sure, less than 2
So like
years.
I said, the IBD has bimodal age distribution.
Yes.
5 and 50 to 80. So first group 15 to 25, second group 50 to 80. Bimodal age distribution.
Okay. And the other differential is Maker's diverticulum. The points for is bloody stool. Points again is there's no symptom of intestinal obstruction. Other differential that we need to consider, it can be caused due to bleeding disorders like hemophilia or factitious or injury or trauma, either accidental or non-accidental injury. And then for investigation, for discharge, full blood count was done to see any show any anemia or any evidence of infection. We can see the white cell count, platelet level, if it is associated with HUS. However, for discharge, it was normal. And then blood culture, but we can also do blood culture and sensitivity, coagulation profile to rule out any coagulopathy, and then renal profile to see the dehydration status, renal function, and also any electrolyte imbalance. And we can also do ABG to rule out metabolic acidosis, which
Why
is
ABG? Why ABG?
To see the metabolic acidosis, which can be complication from the diarrhea itself.
Yeah, but okay, if you have metabolic acidosis, you expect the patient to be tachypneic.
Yes.
So according to the clinical picture, your patient looks well and no signs of dehydration. I will not be hurried to do ABG. You know, ABG is painful when you break the artery.
Yes.
So I will not be hurried to do ABG. Okay.
Okay. And then for stool,
Sorry, doctor.
Okay.
Can we do VBG instead?
You can do if you want, but you just wastage of resources. And you know the economic status now. Don't do something is not needed. Once the patient looks well, comfortable, not tachypneic, no signs of dehydration, not needed. Okay.
Okay, doctor.
Okay, for stool, we can send for microscopy and culture, for ova and cyst, and for rotavirus screening if we suspect it is caused by viral. However, there's no result mentioned for this investigation.
Okay, rotavirus, stool for rotavirus. Do you think it is important for us?
For this
You think
case,
it will
no.
change the management?
For this case, I think no need.
Why this case no need?
Because rotavirus usually doesn't cause the bloody stool, so it is less likely for this case.
Okay. Anyhow, even if you have a child with diarrhea without blood and you think the cause is rotavirus, if you want to check rotavirus, it may help you maybe in isolation of the patient in certain corner, precautions, but it will not change the management. In fact, it is not needed. It is not needed. It is advisable. It is advisable if you work in hospital that any child with diarrhea you put in certain corner and take the precautions. Whether it is rotavirus or another virus, you need to take precautions. So in fact, rotavirus is not needed. I know they do it. Also in UM, they do it. But they do it because they use, like they make some studies about the incidence of rotavirus infection, some things like that. Yeah, but for patient management, it is not needed to do that test. Okay.
Okay, doctor. So next, for if patient we suspect to have HUS, we can do urinalysis, whereby we can see any RBC or RBC cast and also proteinuria. And then for imaging,
RBC cast, are you sure RBC cast? We don't see RBC casts.
let's see,
In
okay.
hemolytic syndrome, we don't see RBC casts. RBC casts are seen in
Glomerulonephritis.
yes, glomerulonephritis. So in HUS, there is no glomerulonephritis. There is intravascular hemolysis. There is intravascular hemolysis. So you may see hemoglobinuria, but you will not see RBC casts. You can do peripheral blood film and you see fragmented RBCs in the peripheral blood film. Okay.
Okay, doctor. Thank you. And then for imaging, we can, if we suspect, usually if we suspect for any interception, we can do a abdominal ultrasound where we can see bullseye, and then abdominal X-ray, we can see signs of bowel obstruction like bowel dilatation or signs of intussusception, which is claw sign. And then if we suspect a patient to have IBD in chronic case, we can do endoscopy or colonoscopy plus minus biopsy if needed.
What is the sign of interception you said?
In X-ray, claw sign.
Interception, what is the
Yeah.
sign?
In what?
No, not none. Abdominal X-ray signs, bowel obstruction, interception. What is the sign of interception by ultrasound?
Ultrasound, from what I know, bullseye. Bullseye sign.
Bullseye.
Donut appearance.
Donut, yes, donut. Donut, yes.
Don't know.
Okay. Very good.
Okay, and let's move on to management. So if this patient present in acute, so we need to resusc the airway, breathing, and secretion, and then we need to assess the vital sign the signs and monitor them because patient can develop shock. And then for hydration, we assess the hydration status and classify them whether mild dehydration, moderate or severe dehydration. The treatment plan is at home. However, this child was admitted to hospital. He is well alert, there's no symptom generally as usual, and the skin turgor was good. Treated with a bloody stool. So he need to be admitted to investigate for the exact causes
So,
lah.
open
And
question,
then
what are the red flags of diarrhea? What are the indications of admission when we have
from what
diarrhea?
I know, the red flags is altered sensorium, bilous or bloody, and then a presence of sinuses, excessive irritability, any rashes, toxic looking, fever, tachypneic or increase in capillary fill time, and also any signs of IBD like arthritis or pre-annulation. And of course, in a young age like less than 6 months, we need to be admitted to monitor them.
Okay, your answer is correct. Your answer is correct. But you see, we can make arrangement for the answer. Yeah, we can categorize. So if you ask me what are the indications of admission for a child with diarrhea, number one, severe dehydration. Why severe dehydration? Because severe dehydration cannot be managed by ORS. They need IV correction. Number two, which is a broad category, suspicion of other diagnosis. Suspicion of other diagnosis. So what you mentioned is altered sensorium, cyanosis, blah blah blah. What irritability? All these may make you suspect other diagnosis. Always remember, diarrhea is not only gastroenteritis. Diarrhea is not always gastroenteritis. Diarrhea may be UTI. Diarrhea may be sepsis. Diarrhea may be meningitis. So that's why if you see anything not compatible with just gastroenteritis, you suspect other diagnosis, you need to admit. The other point, number three, is the age. 6 months. What I know, we admit young infants, usually first 2 or 3 months, like that. And we treat them as sepsis, especially neonates, first month of life. If they have diarrhea, so you have to admit them and take a blood culture and treat as sepsis. Neonate with diarrhea, you must treat as sepsis. So that's the age group. Number four, intractable vomiting. If the child with diarrhea has intractable vomiting means once the patient takes something in the mouth, spit it immediately. Doesn't stay in mouth at all. So that one needs admission, needs IV drip, because that one cannot take ORS. And number five, very poor oral intake. Very poor oral intake means the child doesn't drink. Does not mean the child doesn't eat. You have to be careful. You ask if the child is able to eat. If the child is not able to eat but able to drink, still okay. We can send home. But if the child is unable to drink, we must admit. And number six, presence of the blood in the stool. So again, we repeat. Number one, severe dehydration. Number two, suspicion of other diagnosis. Number three, the age group. Number four, intractable vomiting. Number five, very poor oral intake. Number six, presence of the blood in the stool. These are the indications of admission when we have diarrhea. Can someone repeat these 6 points?
So for number one, it is dehydration. Number two, suspicious of other diagnosis. Number three, the age. Number four, intractable vomiting, very poor oral intake, and also blood in stool.
Very good. Very good. Correct. Okay, carry on.
So, for this child, he was given ORS solution. So how to give ORS? In child less than 2 years, we can calculate 10 milliliter per kilogram of ORS per loose stool. Or if we didn't know the weight, we can use 50 to 100 milliliter per loose stool. So we advise mother to give frequent small sips of the ORS from a cup or spoon to the child.
You
And
see,
if
1 minute, the dose of ORS which you mentioned now, this is a replacement. Per loose stool. You give per loose stool. You say 10 ml. Yeah, or if you don't know the weight, 50 to 100 ml per loose stool. That is replacement of ongoing loss. That is replacement of ongoing loss. Means if the patient has fair hydration. But if the patient has mild dehydration, you need to correct that mild dehydration first. Or if the patient has moderate dehydration, you need to correct the moderate dehydration first. How to correct mild dehydration or moderate dehydration by ORS? Anyone can answer? How much the amount if there is mild dehydration or moderate dehydration? If mild dehydration, we correct by 50 milliliter per kilogram over 4 hours. If moderate, 75 milliliter per kilogram over 4 hours. And we give it slowly. We give ORS slowly by syringe. We prepare the solution in the cup and we give it by syringe slowly. Okay? Carry on. I can't hear you. Alya, I can't hear now.
Alya
I'm
mute.
sorry. I'm sorry. Okay. So for nutrition, we need to encourage orally aspirated. For this child, he already non-breastfed, so we encourage the mother to give more extra fluid and also give more extra soft food like porridge like that to hydrate the child. And then for the antibiotics, for the choice of drugs, it is either antibiotics or antiparasitic. Like for this child, it is most likely caused by bacteria, so we can give antibiotics. So the choice is ciprofloxacin, ceftriaxone, and azithromycin. However, for this child, he was given IV ampicillin. From what I read, ampicillin also can be given to child with bacillary dysentery. However, recent studies showed that some of the like Shigella dysentery develop resistance to the ampicillin. So the better choice is ciprofloxacin, and then second line is ceftriaxone or azithromycin. So if it is causes by parasite, we can give metronidazole. And then dysentery is one of the notifiable disease here in Malaysia, so we need to notify to the nearest district health office. So the last one is about prevention. So we need to prevent the spread of disease and also prevent the complication to the baby itself. So to prevent the spread of disease, as this disease can spread through fecal oral. So we need to ensure good hand hygiene, uh, good safe and clean bottle or utensil, safe and clean food preparation. We must also avoid raw food and avoid share item with infected person because it can spread to fecal oral, and then dispose the diapers properly. And the last one is prevention for diaper rash because baby might develop complication to the skin due to the frequent bowel output. So we need to change the baby's diaper frequently and then clean the baby with water instead of wet wipes, and then use diaper cream if needed. That's all.
Any questions? Any questions to Alya?
No.
No questions. Okay. So let's discuss something. Do you have another case after this? Or only one case? Did you prepare one or two cases?
We prepared 2 cases.
Mm-hmm.
2 cases, Doctor.
2 cases, is it?
Yes.
What is the other case? What system is the other case?
The renal system.
Okay, okay, fine. So let's just discuss something about this case. You go to the whiteboard. Okay. So now this patient has bloody diarrhea. A bloody diarrhea.
Excuse me, doctor.
Can see, okay. Can see now?
Yes.
Yes, Doctor.
Yes.
Okay. Bloody diarrhea. So receive it ORS and receive it antibiotic. So antibiotic because we think it is bacterial. We think it is bacterial. Now what about the diet? What do we need to
Continue
provide for diet?
breastfeeding.
Should we stop breastfeeding? The patient unfortunately are not on breastfeeding, but should we stop the milk?
Should we encourage?
During diarrhea, should we stop the milk?
Continue.
No.
We have
No,
to
we don't
continue.
stop the milk. Yeah, we don't stop the milk. Yeah, we don't stop the milk. We don't stop the milk unless the patient develops secondary lactase deficiency. Secondary lactase deficiency, which is uncommon. Secondary lactase deficiency. Because we know lactase is at the brush border. Lactase at the brush border when we have infectious diarrhea, especially if we have rotavirus or if we have giardiasis, damage to the lactase may happen. Then the patient develops secondary lactase deficiency. And that one will present with persistent diarrhea or recurrence of diarrhea. It is uncommon. In that case, if you have secondary lactase deficiency, you may stop the milk temporarily only. Only temporarily. What is the recommended food and the avoided food? Now the child is just 6 months, just starting weaning. But let's say an older child, recommended food.
We have to avoid fatty food and increase in the simple sugar like juices, carbonated soda.
Carbonated soda. What do you want about carbonated soda? You want to avoid, is it?
Avoid, yes.
Yes. Okay. So you are telling us about avoid. Why you want to avoid carbonated drinks? Why?
There's simple sugar.
What else? What about coca and coffee?
Juice.
Okay, these have high sugar. Okay, I agree with you. Carbonated drinks have high sugar. What about coca? Coca or Pepsi or coffee?
Coffee, well, the GI motility, because
there's increased bowel movement. Increase bowel movement. And this is not good. We don't want to increase bowel movement. Patient already has diarrhea. If you increase bowel movement, you'll have more diarrhea. So avoid coca, avoid coffee, avoid spicy food, avoid carbonated drinks. Avoid. These increase bowel movement. Carbonated drinks, like you said, have sugar, and coca, coffee, and spicy food increase bowel movement. Recommended food. What's recommended food? Brat.
Soft diet.
Soft diet. Okay, soft diet. Yes. Example. Okay, brat. Remember brat. Brat. B-R-A-T. Brat. B for banana. But use a bit hard banana. Don't use very soft banana, because very soft banana may give opposite effect. Banana are for rice. So good, huh? Your Malaysian food is good. You have the rice and you have the banana. A for apple sauce. Apple sauce. And T for toast. So banana, rice, apple sauce, and toast. This is the recommended food. Okay. Any question?
Doctor, how about fruits? Other fruits than banana?
Can take fruits, no problem. Yeah, it is recommended to take banana, but if you are allowed to take other fruits. You are advised to avoid only these: carbonated drinks, coca, coffee, and spicy food.
Okay, and Doctor, I have also another question that certain child also being advised for avoid drinks like juices. Why?
Juice, because sugar. Juice, like carbonated drinks, juice has high sugar. Artificial juice has high sugar, has added sugar, and this high sugar will increase the diarrhea. You avoid also. Yes, you avoid. If you make natural juice at home with the natural fruit, that's no problem. But the one which we buy from the market all has added sugar, so you have to avoid it.
Okay, so natural juice will be okay, like
yeah,
apple juice.
natural juice okay. If you use it, but you make it in the home by the blender, no problem. Without adding sugar.
Okay.
Without adding sugar.
Okay, right. Okay, thank you.
Welcome. Okay, so let's take a break for 5 minutes before we start the second case.
Okay,
Take 5 minutes.
Okay, Doctor.
Okay, thank you. Okay. So the presenter now is
Me, Doctor.
Fitria. Okay.
Just now Dahlia said she want to ask question.
Yes.
Yeah, yes. Regarding the secondary lactate deficiency. So, how long that we should ask the mother to stop the feeding?
Only 3 weeks.
Okay.
Only 3 weeks. It is uncommon. It is uncommon. Secondary lactase deficiency is uncommon. So that's why, for the general practice, we don't ask to stop breast feeding or formula. We don't ask. To be careful in the exam. Yeah, because if you mention it early, if you say it, then it may give impression which is not good about you. Because the recommendation is to continue. Secondary lactase deficiency is uncommon. And it usually happen after rotavirus, which is unlikely in this case, or after giardiasis, or after cryptoboridiasis. These are the common. The other thing, you think in secondary lactase deficiency, if the child is very young, less than 3 months, or if the child has massive volume loss. If we look at our patient here, he is not less than 3 months. There is no massive volume loss. It is not rotavirus. It is not giardiasis. Unlikely to be cryptosporidiasis because cryptosporidium comes in immunocompromised. So we think it is not there in this case. And if you face this secondary lactase deficiency in your life, you stop only temporary. 3 weeks enough for the lactase to regenerate in the brush border.
Okay, thank you, Doctor.
Come.
Can I start now?
Can.
Okay, so my case is case discussion on nephrotic syndrome. Okay, for the chief complaint, my patient, Azim, 8 years old and 3 months old Malay boy with underlying small ventricular septal defect presented to Hosh's emergency department for history of fasting for 3 weeks duration, associated with worsening facial puffiness and also bilateral lip swelling for 2 weeks duration. Okay, the patient was this history was taken from the mother and also the patient himself. The patient was appearing well until 3 weeks prior to admission, where he developed a faulty urine for about 3 weeks duration, and it was noticed by the patient, and it was described as darker in the color. However, the patient denied of any reddish discoloration of the urine, no alteration of the urine volume and also frequency. He also did not seek any medical attention since it thought that it was benign. And then it was also associated with facial puffiness for about 2 weeks duration, and the mother said that it was noticeable around the orbit of the eyes, exacerbated in the morning and gradually resolved throughout the day. And then the facial puffiness worsened throughout the 2 weeks duration. He also developed bilateral lower leg swelling for about 2 weeks duration. Initially, it was up to the ankle only. However, it extended up to the knee for the past 1 week. And then it was painless, not associated with any skin color changes. And he also experienced heaviness upon walking. He also heavy increase in the weight for about 6 kg for the 2 weeks duration. It was unintentional and gradually increased for the past 2 weeks. He also developed abdominal distension for about 5 weeks duration. And on the day of the admission, the mother noticed there was also a scoliosis swelling. And then this was his episode, the first episode of the symptoms. He was then brought to KK Cemamoy and was referred to emergency department of Hoshia's property management. Otherwise, he denied of having any shortness of breath or reduced in effort tolerance that may suggest heart failure since patient had underlying ventricular septal defect. He also did not recall of any preceding fever or sore throat prior to the appearance of symptoms. There was also no polyuria, polyphagia, polydipsia. And then the patient was not a known case of diabetes. He also denied any rashes, prolonged fever, and also joint pain. And there was no autoimmune disease running in the family or renal disorder. And then he also denied of taking any medication that is nephrotoxic medication that can cause nephrotic syndrome such as penicillamine, GORD, and also NSAID. There was also no constitutional symptoms or underlying malignancy. The patient also denied any complaint of abdominal pain, fever. There was also no sharp chest pain or shortness of breath that may suggest the complication of the could be nephrotic syndrome. And then for the systemic review, there was no active complaint, other active complaint apart from the presenting complaint. Okay. And then for the past medical and surgical history, this was his third hospitalization. The first admission was he was 2 years old due to bacterial pneumonia. He was discharged and recovered fully upon discharge. And the second admission was when he was 4 years old due to alleged detergent ingestion. And then he also had underlying small BST diagnosed after birth during his admission in an ICU since he was born preterm at 31 weeks. And then the echo at that time the echo was done and confirmed the defect. However, there was no intervention done since he was asymptomatic and the defect was also small. And then currently he was on regular follow-up with IJN and then not on any medication for his BST. Otherwise, the patient had no known other medical illness, and then there was also no significant surgical history. Okay, the patient also had no known drugs of food allergy, currently not on any medication, and also denied of taking any history of any traditional drugs or over-the-counter drugs. And then for the immunization history, he already completed the immunization schedule up to the schedule to the accordance of the Currently he is 8 years old, so he complete up to the age. So for the birth history, for the antenatal, the mother had pregnancy-induced hypertension during pregnancy. However, unsure of the event at that time, like what kind of hypertension in the pregnancy. And then for the intrapartum, the patient was born via emergency lower segment cesarean section. Since at that time the mother had hypertension, I presume it was a preeclampsia, and then the patient was delivered at the preterm at the 31 weeks with birth weight of 1.45 kg, which is a very low birth weight. Yeah. And then he was then warded in NICU for about 2 months due to the preterm. And then at that time he was diagnosed with a small BST. However, he had no other complications of the preterm. And then for the growth and development history was also normal. Currently, he is a second grade in SK Felda, and then he performed well in his study, and there was no also learning impairment. Okay. For the nutritional history, he was breastfeeding up to the 2 years of age. However, he was not exclusively breastfeeding for the first 6 months, since he was admitted to an ICU for 2 months. So the mother had difficulty to give breastfeeding to her child. So the hospital introduced the formula milk to the patient and provide the formula milk to the patient. And then the patient started weaning as well at the 6-month-old where soft diet was introduced. Currently, the patient is able to tolerate already with normal and balanced diet, and he is not a picky eater.
You see, the hospital should be the place where the education comes about breastfeeding, but unfortunately, the hospitals here and everywhere, even in my country, they make the wrong things regarding breastfeeding.
Yes, sir. Okay. So for the family history, so both of his mother and father was still alive and healthy. There was no history of consanguineous marriage, and then currently his mother had hypertension on medication and diabetes on oral hypoglycemic agent, and his father had no non-medical illness. There was also no history of autoimmune disease or any connective tissue injury running in the family. So he is the youngest child with the two elder brother and sister. All of them are healthy and there was no similar presentation in the family. And then for the personal and social history, he currently lives in Tanda Kumasa together with his family with adequate housing facilities. And then his father working as Felda penal worker while his mother is full-time housewife with household income of about 2,000 per month. Both of his parents are non-smoker and do not drink alcohol or no high-risk behavior. And the nearest clinic kesihatan is KK Cimomoi, which is 50 minutes from their home. So in summary of the history, Azim, 8 years 3 months old Malay boy with underlying small BSD, presented with history of passing out 40 urine for 3 weeks duration, associated with generalized edema worsening for the past 2 weeks, no history to suggest prior infection, diabetic nephropathy, heart failure, drug-induced nephrotic syndrome, or any connective tissue disease. So, can I proceed to physical examination?
No, before you go to physical examination, let's ask the group what's the likely diagnosis from the history. Okay, open question. What do you think the likely diagnosis?
I think my first progression is syndrome.
Nephrotic syndrome. Why nephrotic syndrome?
Present with fatty urine of proteinuria.
Why fruity urine? Why the urine is fruity?
Proteinuria. Because okay.
The urine is high. The urine fruity because of high which protein?
Albumin.
Albumin. Do we normally have protein in our urine?
Sorry, doctor.
Do we normally have protein in our urine?
It's semi-normal if it's caused by exercise or by illness.
Okay.
Usually we don't have protein
albumin
in our urine.
We don't have albumin. Normally we don't have albumin. Yeah, we don't have albumin. Why we don't have albumin? in the urine?
The
Albumin is
negative,
less molecule.
Negative charge,
Negative
yes. Negative
charge.
charge. So the barrier, the glomerular basement membrane is negative
So
charge, and albumin is negative charge, so the albumin does not pass. Albumin does not pass. Yeah, but normally we shouldn't have any albumin in our urine unless transient proteinuria, like you said, fever, exercise, dehydration, cold exposure, yeah, or seizures, or heart failure. That may have transient proteinuria. So fever, exercise, dehydration, seizures, and stress that can cause transient proteinuria. The only protein which is found in urine is TAM horsefall protein. Have you heard about that?
Can you repeat that there? Sorry.
TAM, T-A-M-M, T-A-M-M. Horse, H-O-R-S, F-A-L-L. TAM horsefall protein.
Okay.
That's the normal protein found in urine. Yeah, it is a glycoprotein. In fact, it is a glycoprotein, and it prevents UTI. It prevents UTI, and it is responsible for making the urine like gelatinous. You see, if someone urinates on one surface, come after some time and see the urine, you'll find the urine gelatinous. It is not like the water that it will dry and disappear. If you pour water on the floor, so with time the water will disappear, will evaporate, and the area will be dry. If you pour urine on the floor, yes, the water part of the urine will evaporate, but then some gelatinous part will stay on the floor. That gelatinous part is TAM horsefall protein, which is protective. Other than that, we shouldn't see any protein in urine. So in this case, you suspect that this patient has nephrotic syndrome because you saw the patient has fruity urine, so you think this fruity urine because of albumin. Okay, that's good. Okay. Okay, carry on.
Okay. So for the physical examination, he was either unconscious, not in pain, or not in respiratory distress. And
Is the smell is or
yes. Can you hear me?
because I just can see white, or is it just me?
Can you see the slide?
I can see the slide.
Oh, okay.
Yes.
I think it's my problem.
Okay. So the patient was able to lie in supine position without having difficulties, and there was during that clutching, there was infusion of the albumin to the patient Banula. Otherwise, there was no ID attachment, and the patient is not pale, jaundice, or sinus. There was noted a periorbital edema and also bilateral ankle edema extending up until the mid-shin area. However, there was no visible and palpable lymphadenopathy, and then the GBP also not raised. And then for the anthropometric measurement, the patient, I said just now, the patient gained weight about 6 kg for the past 2 weeks, and it was unintentional. However, the growth parameters was still in normal parameters. And also the vital sign, he is a normal tensive, not afebrile, not tachycardia or not tachycardia. And then for the abdominal examination, the abdomen was distended. However, there was no stretch or scratch mark. There was also no superficial dilated veins and also no scarnotate. The hernia office were also intact. Sorry, doctor.
What is the importance of abdominal examination in this case?
Since this patient complained of abdominal distension and also increasing weight again, so we want to find if there is any ascites.
Any ascites. So ascites is part of the nephrotic syndrome.
Yeah.
Okay, and ascites part of nephrotic syndrome. And once we treat nephrotic syndrome, if the patient improve, no more protein in urine, this ascites will resolve. Is there any serious complication which may happen?
Spontaneous bacterial peritonitis.
Very good. Spontaneous bacterial peritonitis. So what is the organism? What is the common organism which can cause spontaneous bacterial peritonitis?
E. coli.
What is more common?
Anaerobic organism.
What is it?
Anaerobic organism.
No, more common.
Staph aureus.
No, not Staph aureus.
Klebsiella.
Not Klebsiella.
Not sure that's the
Streptococcus pneumonia. Streptococcus pneumonia. So most of this question, most of the students, they don't answer because they think that Streptococcus pneumonia, something in the pneumonia here or in the meningitis. Yeah, so Streptococcus pneumonia is the most common organism. It is the most common organism which can cause spontaneous bacterial peritonitis. So if the patient with nephrotic syndrome develop abdominal pain, come and see, look for spontaneous bacterial peritonitis. What else can cause abdominal pain other than spontaneous bacterial peritonitis?
patient can develop diarrhea.
Diarrhea. Okay. My question is, if the patient has abdominal pain, if he has nephrotic syndrome and develop abdominal pain, so you need to think in spontaneous bacterial peritonitis, this is one, and you need to think in something else, which can cause abdominal pain. Hypovolemia. Hypovolemia can cause abdominal pain. And we know patients with nephrotic syndrome, they are at risk of hypovolemia. And they may go into hypovolemic collapse. Why abdominal pain? Because of hypovolemia?
Is it because of the ischemic bowel?
Exactly. Very good. Very good. Yeah, because decrease blood supply to the bowel, so ileus will happen. That's why the patient develop abdominal pain. Okay, very good. Carry on.
Okay, so upon percussion, revealed ascites, which is positive cystitis and also foot thrill. And then upon genital examination, there was a Scottish swelling noted, and the translumination test was positive, indicates fluids in the lump, and also the swelling was non-tender and also soft inconsistency. Okay, rectal examination was normal. And then for the cardiovascular examination, there was no evidence of pleural effusion. However, there was no evidence of any cardiomegaly, and then not risk in JVP. And also there was a murmur heard, which is a grade 3 pensionic murmur basal at the left lower sternal edge, which indicates the patient had a BST. And then for the respiratory examination, there was no evidence of pleural efficiency in this patient. Okay, for the case summary, Azim, 8 years, 3 months old Malay boy with underlying small BSD, presented with history of passing out 40 urine for 2 weeks duration, associated with generous edema, was renewed for the past 2 weeks. No history to suggest prior infection, diabetic nephropathy, heart failure, drug-induced nephrotic syndrome, and also connective tissue disease. On examination, there was spiral orbital edema, bilateral edema, and also ascites with Scottish swelling. Auscultation of the precordium confirmed the presence of BSD. As the examination was unremarkable, there was no evidence of pleural effusion. So my provisional diagnosis in this case is idiopathic nephrotic syndrome, because the patient has history of 40 urine for the past 3 weeks, associated with generalized edema, and also the nature of the periorbital edema, it was exacerbated in the morning and resolved in the evening, and then the patient had no secondary causes of the nephrotic syndrome, which is elicited from the clinical findings. And then for the okay, that's for the points for idiopathic nephrotic syndrome. The points against, there was no. Okay. And then for my differential diagnosis could be nephrotic syndrome secondary to other causes, which could be further investigated suspicious. However, there was no points for in the history and also physical examination. And then for the nephrotic syndrome, the patient may have nephrotic syndrome since patient complain of dark urine color, which may could be a hematuria, and also patient also had generalized edema. However, for the points against, there was no oliguria, no hypertension, and also no preceding history of
Very good, very good. Yes, very good.
and then the patient also could be having heart failure secondary to BST, since patient had generalized edema, and however, same patient had underlying ventricular septal defect. However, the points against, there was no autopnea, no paroxysmal nocturnal dyspnea, there was no shortness of breath basically, and there was no reduce in effort tolerance or no signs. That's
Good.
for differential. Okay. And then for the investigation, so to confirm the nephrotic syndrome, I would like, and also to check for the baseline blood investigation, I would like to do a full blood count to check for any evidence of infection, which is look at the WBC. However, in this patient, the result was normal, the full blood count, and I would like to do a liver function test to check for the serum albumin level, which is could indicate hypoalbuminemia less than 25 in nephrotic syndrome, and also to do a renal profile to look at the urea and creatinine level if there is any renal problem, and then to look for and to do a lipid profile, evidence of hypercholesterolemia, and for the first and simple bedside test we can do is a urinalysis to look at the proteinuria, since patient complain of proteinuria. And to diagnose a nephrotic syndrome, so we need to do a 24-hour urine collection to quantify the protein per day. We can also do a urine protein creatinine index, which is in the morning, to diagnose the nephrotic syndrome. And then for the
Okay, now we will stop here. So 24 hours urine protein. So what is the normal urine protein?
Less than for the in nephrotic syndrome, for the per day it will be more than 1 gram. However, in normal less than 1 gram.
So mean when you have proteinuria more than 1 gram per day, means it is glomerular cause. It is glomerular cause. Large proteinuria. According to body surface area, how much proteinuria in nephrotic syndrome?
I'm not sure, doctor.
Okay, so normally we shouldn't have, like I said, we shouldn't have albumin in urine. We shouldn't have albumin in urine. We shouldn't have. If you have, it will be very small amount. It will be very small amount, less than 4 milligram per meter square per
hour.
4 milligram per meter square per hour. 4 milligram per meter square per hour. So we should have that. If it is more than 4 milligram per meter square per hour, it is high. It is high. In nephrotic syndrome, it can reach more than 40 milligram per meter square per hour. Yeah, 40 milligram per meter square per hour. Or if you want to calculate that 1 gram per day, that is a simple figure. If more than 1 gram per day means it is glomerular proteinuria. If less than 1 gram per day, it is tubular proteinuria. And then you need to go to the urine protein creatinine index. Yeah, or creatinine protein ratio. Creatinine protein ratio. So what is the normal urine protein creatinine ratio?
For in nephrotic syndrome,
yes.
If it is more than 200 milligram per millimole, it's considered
very good.
Nephrotic syndrome.
Yes, more than 200 milligram per millimole. So this is your answer. Yes. So these are the units which you use in Malaysia. If you go and read from Nelson, you'll see different numbers. You'll see very small numbers because Nelson is using different units for creatinine and for protein. That's why the number is very small in Nelson. But what you use here in Malaysian hospitals, you use more than 200 milligram per millimole. Okay? So they ask in the exam, they ask about the nephrotic range proteinuria. This one 24 hours, how many milligram per meter square per hour, and they ask about urine protein creatinine ratio. Do you know how to calculate body surface area?
I didn't know that.
Anyone know from the group?
Is it the same like in burns that we use either the 9 rules or the chart? I don't remember the chart's name.
No, the rule of 9 is not to calculate surface area. Rule of 9, that one is to see how much involved from your surface area relatively. For example, if you have burn, see how much of your body surface area, the percentage of your body surface area involved, but does not calculate body surface area. Rule of 9 does not calculate body surface area. To calculate body surface area, you have equation. Now, if I ask you, I think you saw me before, is it?
Sorry, Doctor?
You saw me before in...
yes, just before the TKP.
Yes, just one day before the VTV. Yes.
Yeah.
Okay, guess how much my body surface area? Yes, open a question. Can you guess how much my body surface area?
I don't know.
You don't know, okay? Okay, I am 2.16 meters square. 2.16 meters square. This is my body surface area. So 2.16 meter square. The body surface area is calculated from equation. It is calculated from equation. So the equation for body surface area, we take the square root of weight by kilogram times height by centimeter divided by 3,600. 3,600. Can someone of you give us the weight and the height for any one of you who wants to tell us about his or her weight and height? Anyone? We want to calculate body surface area here.
I cannot tell.
Okay, yes.
Weight 45.
45 kilogram, okay.
Height 158.
158 centimeter, okay. So calculate together. So your body surface area will be 45 times 158 divided by 3600. Okay, I bring my calculator. You calculate also. Everyone calculate. Okay, so I brought my calculator. So 45 times 158 divided by 3600, we will get, with my calculator. So 45 times 158 divided by 3600
1.975.
1.975.
Yes.
I think my calculator has problem. So here body surface area is 1.975.
No, not yet. Not yet.
Yes, the square
Like the
root.
square root.
For
So
after
take the square root.
I got 1.4.
1.4. Did you get the same number? Calculator is not good. I will not use. You got 1.4. What about the others?
Yes, I got the same.
1.4 meters square. Okay.
Similar answer.
Similar answer. Okay, good. So no need for me to check. So this is the usual. I mean, those who have big body size, usually around 2, like me. The average people from 1.4 to 1.8. Those adolescents, 1. Children, younger children, less than 1. Younger children, less than 1. That's the usual body surface area. The other way which you can calculate body surface area is the nomogram. Nomogram. Nomogram, you have weight here, and you have height. So for example, for you, we come here to 45 gram, and we come for the height 158, is it?
Yes.
158. So in between there is one middle line here, body surface area. Body surface area. So what we do, we connect the weight and the height. We connect them. We use the ruler connect. The cross point here is the body surface area. This is nomogram. Okay. Okay, carry on.
Okay. So let me carry on with the ID investigation. So we can do ID investigation such as chest X-ray to look for any evidence of coagulation, but it was not indicated since there was no evidence in the history and also in the physical findings. And then in this case, renal biopsy is not indicated. And then we also could offer ID investigation to rule out secondary causes of nephrotic syndrome. However, if we doubtful based on history and also physical evidence, in this case, we don't need to do it. Okay. And then this is the result for this patient. We can see at liver function test, the total 14 was low, and also the albumin was very low, which is 14. So in nephrotic syndrome, it was diagnostic when the albumin is less than 25. And then for the renal profile, we can see that it is normal. And then for the lipid profile, we can see the total cholesterol is high and also the triglyceride is high. So the evidence of hypercholesterolemia, hyperlipidemia. And then this is the result for urinalysis. So the protein was 4+. However, this is not a 24-hour urine protein, so we cannot diagnose based on the urinalysis. So I'm sorry for the urine protein creatinine index. This is the value was not in Malaysia. Malaysia punya unit. So I'm not sure about the result. Since I got it 2.1.
2.1. Total protein gram per deciliter.
I'm sorry, doctor. I would like to ask regarding the urine protein creatinine index eventually because in the books that if you want to calculate the total protein also creatinine, we get it from the like it is a special investigation, or we can get the protein and creatinine level based on the like diet or you.
There isn't investigation.
Oh, special. Oh, okay.
Yeah, but it is strange. This one you are using gram. Creatinine is not a gram per deciliter. Creatinine milligram per deciliter, milligram, and total protein is never 320 gram per deciliter. It is not 320. Impossible.
Yeah,
impossible.
There was a problem with the result of this investigation. Okay.
Yeah, we cannot see 320. 32. 32 gram per liter. Gram per liter, or 3.2 gram, or 3.2 gram per deciliter. So protein is by gram. Protein is by gram. Creatinine is by milligram. Yeah. So from where this result?
Oh, I take it from the previous case write-up for the result for the nephrotic syndrome.
Yeah, you know, there is something wrong. Something wrong.
Oh,
yes.
yes.
Something wrong. Yes.
Okay. And then that's for the result and for the management of this patient. So the principal management of the nephrotic syndrome. First, we want to reduce the edema.
Okay. Before we go to the management, let's discuss. So now we confirm that this patient has nephrotic syndrome, and you told us the definition of nephrotic syndrome. Do we need to do renal biopsy?
In this case, no. Since we
Why?
For the renal biopsy, it is indicated this patient is not respond to the primary treatment of the nephrotic syndrome, which is steroid, which is not responsive to the steroid for restoration. And then if we suspect there is a secondary causes of the nephrotic syndrome.
What makes you suspect secondary causes?
If patient complain of either systemic complaint, which could be a joint pain, we can suspect a patient have SNE, so we can do a renal biopsy to look for lupus nephritis, and then
you see, if you suspect other cause, yes, hypertension is very important. Your patient has normal blood pressure. If the patient has hypertension, if the patient has gross hematuria, and if the patient has abnormal kidney function, or the patient has steroid resistant, does not respond to steroids. These are the 4 categories. If we go to our patient, you show us the urine FME here. We see the urine FME, the RBCs. Yeah, so almost no RBCs. Almost no RBCs. Yeah. If we go to the kidney function, the urea and creatinine, they are normal. We go to the kidney function, the urea is 5.5 millimole per liter, creatinine 45 micromole per liter. So normal kidney function, no gross hematuria, and the blood pressure. We go to the blood pressure.
Blood pressure.
Yeah, we go to the slide of blood pressure.
The vital sign 160.
Yeah, 100/60.
60.
So for 80 years old. So normal blood pressure, normal kidney function, no gross hematuria. So it is not indication for renal biopsy. Indications of renal biopsy, like you said, if you suspect other diagnosis. What makes you suspect other diagnosis? Either abnormal kidney function, or hypertension, or gross hematuria, or steroid resistant. Steroid resistant. What is the definition of steroid resistant?
Patient is unresponsive to the steroid therapy after 4 weeks.
After 4 weeks of steroid therapy. Yes, this is correct answer. Yes. Yeah, failure to achieve remission after 4 weeks of steroid therapy. 4 weeks of steroid therapy. Yeah. If you go deep in the nephrology references, some of them increase it to 8 weeks. They found some children, if you extend the period of steroid treatment to 8 weeks, some of them may respond. So some references, they will tell you 8 weeks. But you can use 4 weeks, no problem. That's I think that's the one in the pediatric protocol. Failure to achieve remission after 4 weeks of steroid therapy. What is definition of remission? Open question. What is definition of remission?
What the lipsticks, the nail,
Remission.
trace or 1+.
Yes.
For
Remission
the
definition.
There was a nil or trace unlistic protein for the 3 consecutive days.
Very good. Correct answer. Negative or trace protein in urine for consecutive 3 days. Very good. That is definition of remission. Okay. So now our patient was investigated already, and he doesn't need renal biopsy. So likely idiopathic nephrotic syndrome or steroid responsive nephrotic syndrome. Steroid responsive nephrotic syndrome. So let's talk about nephrotic syndrome before you go to the management. We need to understand the pathophysiology of nephrotic syndrome. The pathophysiology. So, nephrotic syndrome, there is damage to permeability properties. Damage to permeability properties. There is loss of negative charge on glomerular basement membrane. Glomerular basement membrane. There is a fusion of podocytes. So this will lead to albuminuria. Albuminuria. When we have albuminuria, we will have low serum albumin. Low serum albumin. Okay? Tell me what will happen when we have low serum albumin.
Increase in cholesterol.
Reduce in oncotic pressure.
Decrease in oncotic pressure, okay? Can you see the whiteboard?
Yes, doctor.
Okay. Decrease oncotic pressure. Decrease oncotic pressure. What will happen when we have decrease in oncotic pressure?
Will increase in hydrostatic pressure, and also will be shifting of the fluid from the intravascular to extravascular.
Very good. So when we have decrease in oncotic pressure, we have fluid shift, which will lead to edema. This fluid shift will lead to edema and decrease intravascular volume. Edema, decrease intravascular volume. Intravascular volume. So there is edema because of fluid extravasation, and this edema will decrease intravascular volume. So when we have decreased intravascular volume, which hormone will be stimulated?
The nervous system will be stimulated.
Yes.
Renin, angiotensin, aldosterone.
Very good. So renin, angiotensin, aldosterone system. Renin from where comes?
From the renal.
Which part of renal?
I'm not sure that.
Okay, others. Which part of renal? Yeah, open question. Which part of renal? You can type the answer. Or the rest of the what which part of renal? I don't hear. I hear only noise. Juxtaglomerular apparatus. Juxtaglomerular. Juxtaglomerular glomerular. Juxtaglomerular apparatus. So from juxtaglomerular. So renin, what renin will do? Renin will convert. Yes, follow with me. Someone tell me renin will it change? What is the function of renin?
It will change from the angiotensinogen that was produced by the liver to the angiotensin 1.
Very good. So angiotensinogen produced by liver, so will be converted by renin. Angiotensinogen will convert to angiotensin 1.
I'm sorry that we cannot see your whiteboard.
Okay. Okay. Can you see renin?
Yes.
Okay. So renin will convert angiotensinogen to angiotensin 1. Angiotensinogen from liver to angiotensin 1. Angiotensin 1. Okay. Then what happened to angiotensin 1?
It will be further converted by the ACE to the angiotensin 2.
Very good. So angiotensin 1 will be converted to angiotensin 2. Angiotensin 2. Angiotensin 2 by the enzyme angiotensin converting enzyme. From where this enzyme comes?
From the lungs.
Very good. Which part of the lung?
From the... I'm not sure.
Okay. Pulmonary endothelium. Pulmonary endothelium. So it comes from pulmonary endothelium. It comes from pulmonary endothelium. So angiotensin 2, what it will do?
It will be increased in the absorption of the water at the renal tubule.
Okay. How increase absorption of water? It will stimulate which hormone?
It will also stimulate the aldosterone.
Aldosterone.
Yeah.
Aldosterone.
So the aldosterone sodium and water absorb. Always water for sodium. Because the body wants to compensate. We have hypovolemia. The body wants to compensate. The body wants to compensate. So aldosterone, sodium, and water absorption. But unfortunately, the water is absorbed. Again, because we have low albumin, it will come out again. Any other hormone is stimulated by decreased intravascular volume.
ADH.
Very good. ADH. ADH. So what is the action of ADH?
Water retention, which is
Yes.
the absorption of water.
Yes, free water retention. It is not sodium, only free water. But unfortunately, water retention, try to compensate. Water retention, unfortunately, this water, again, because no albumin, it will come out. So there is a stimulation for renin and stimulation of ADH. But there is inhibition for one hormone or another substance. Which one is inhibited? There's one substance inhibited. Start with A. Inhibition of? Yes?
I'm not sure.
Not sure. Okay. Any other one? Arterial natriuretic peptide. So there will be inhibition of arterial natriuretic peptide. You see, for renin it is a stimulation. For ADH it is a stimulation. But for A and B it is inhibition. Why? Because A and B normal action is the opposite. A and B enhance the uresis. natriuresis. They call it arterial natriuretic peptide, produced from the cardiac atria. Produced from cardiac atria. So normally it induces natriuresis. When the pressure in the right atrium increase, there is increased volume in the right atrium, distension of the right atrium, so it is produced from the endocardium to enhance the uresis, natriuresis, go out sodium and water. So this one normally protects us from volume overload. So what happened here in nephrotic syndrome, the A and B will feel opposite situation. There is hypovolemia, so it will be inhibited. It will be inhibited in trial to keep the water in. It is very important, nephrotic syndrome, pathophysiology. It is important now, and if you are interested in pediatrics also, it can come in part 1 master exam. I remember in first part, part 1 after first year, there is Viva station. So the Viva station was this one, the pathophysiology of nephrotic syndrome. Okay, clear? Is it clear? Okay. So this is the pathophysiology. Okay, let's continue before you go to the treatment. Now our patient has nephrotic syndrome. Nephrotic syndrome. We understand the pathophysiology. Before we go to the treatment, we want to be aware from the complications. Complications of nephrotic syndrome. Complications. 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 Okay, open question to all. Can you tell me what are the complications of nephrotic syndrome?
Thromboembolism.
Thromboembolism, very good. Thromboembolism.
Hyperlipidemia.
Very good. So thromboembolism. Okay. Hyperlipidemia. Okay.
Infection, which is predisposed to infection.
Infection. Okay. Okay. Yes.
I just want to say DVT, but I think it's under thromboembolism.
Yes, under thromboembolism. Yes, correct. Yes, what else?
The complication of the ascites, just like previously we said about the spontaneous bacterial.
What is it? Peritonitis under infection. Renal failure. Renal failure. Or now the new term is acute kidney injury. Acute kidney injury. Urinary loss of binding proteins. Binding proteins. Hypovolemic collapse. And complications of therapy. Complications of therapy. Complications of therapy. Let's go through them one by one. Let's go through them. Thromboembolism. Thromboembolism. Why thromboembolism? Why?
Loss of anticoagulant. Loss of anticoagulant.
Because of?
Loss of anticoagulant 3, antithrombin 3.
Very good. Very good. Loss of anticoagulant. What anticoagulant is lost?
Antithrombin 3.
Again, antithrombin, very good. Yes, there is lots of antithrombin 3 because you see, proteinuria is not always selective. In nephrotic syndrome, sometimes we have selective. If selective, it is good, means albumin only. But the problem sometimes is non-selective. And we know proteins are negative. When it is non-selective, with loss of the negative charge in the glomerular basement membrane, so many proteins binding proteins are lost. This is the problem when it is non-selective. So antithrombin 3, protein C, protein S can be lost. Yes, then we have tendency for thromboembolism. The other thing is the hyperlipidemia itself and hypovolemia. Hypovolemia is a risk factor. Because of which triad? Which triad is responsible for thromboembolism?
Virtuous
triad. Very good. Very good. Let's go to hyperlipidemia. Why patients go to hyperlipidemia?
Because it's due to compensatory synthesis of protein by the liver.
Okay, compensatory synthesis of protein is the liver. One of them is lipoprotein, correct? Yes. And also loss of lipoprotein lipase. Proteinuria is non-selective. There may be loss of lipoprotein lipase. Lipoprotein lipase. Lipoprotein lipase, this one enzyme, which is a protein, because we know enzymes are proteins, which can degrade lipids. When there is loss of lipoprotein lipase, then we have hyperlipidemia. Infection. Why there is risk of infection?
Loss of immunoglobulin.
Very good, because again non-selective, loss of immunoglobulins and loss of what else? Other than immunoglobulins? Complement. Very good. Loss of complement. Very good. Okay. So when we have infection, what are the 4 common infections? One of them she told us about. In the abdomen, what is the first one? SPP, spontaneous bacterial peritonitis. Second infection?
Cellulitis.
Cellulitis, very good. Cellulitis. Third infection?
Sepsis.
Yes?
Sepsis.
Abscess. The common infection? Pneumonia. They may get pneumonia and UTI. These are the common infections. Any infection can happen. Abscess also may happen, but these are the common infections. Now we go to renal failure, acute kidney injury. Why acute kidney injury? What is the cause of acute kidney injury?
Hypovolemia.
Very good. Hypovolemia. Hypovolemia. What else? If you go to thromboembolism here, where does this thromboembolism happen? Which part? What if you said DVT? One place more common than DVT. DVT is uncommon in children. What's more common? Thromboembolism happen?
Renal embolus. Renal artery.
Renal vein thrombosis. Renal vein thrombosis, which can cause renal failure or acute kidney injury. Renal vein thrombosis. What is the presentation of renal vein thrombosis? Pain, hematuria, and abdominal mass. Pain, hematuria, and abdominal mass. Pain, flank pain, hematuria, and abdominal mass. Renal vein thrombosis, which can cause acute kidney injury. The other thing, infection, because UTI. Infection, UTI can cause acute kidney injury. The other thing, therapy. Therapy itself can cause acute kidney injury. Okay? Next, urinary loss of binding proteins like thyroid binding globulin, thyroid binding globulin, or cholecalciferol binding protein, cholecalciferol binding globulin. These can be lost. So the patient can go to hypocalcemia, can go to hypothyroidism. If you go in the literature, there are some cases reported hypothyroidism with nephrotic syndrome because of diffuse thyroglobulin binding globulin. Hypovolemic collapse, like we mentioned it. So what is the presentation of hypovolemic collapse? What will be the complaint of the child when he has hypovolemic collapse? What is the first symptom before the child collapse?
Dizziness.
Before CNS symptoms, what will happen?
Lethargy.
We mentioned when we talk about spontaneous bacterial peritonitis.
Abdominal pain.
Abdominal pain. So first, they will have abdominal pain before go into CNS symptoms and collapse. Abdominal pain. So be careful from abdominal pain and complications of therapy. So these are the complications of nephrotic syndrome. Okay, any question about complications?
No.
No.
If no questions, we go to your slides. We see the therapy. Yes, continue.
Okay, for the management of nephrotic syndrome, in this case, so the first principle that we want to do in this patient is to reduce the edema, which is we need to restrict the salt and also fluid, and also for the patient, and also we can infuse the patient with human albumin to increase the oncotic pressure back, so there was no fluid shift anymore.
Wait. What is your reference for that?
This is only the principal management that I include, and then I also include.
No, wait. What is the reference? What is the reference? What is the reference for this?
Peace protocol.
BST protocol. I see. Okay. Let's talk about the scientific way, because it is dangerous when you start direct go to edema, reduce edema, human albumin. It is not a routine, you see. If you go during your housemanship, when you see patients with nephrotic syndrome, you will see they don't give albumin to them unless certain conditions. Number one, you tell me management. Number one, admission. First episode nephrotic syndrome. So number one, admission. Why admission?
It is the acute event of the
admission. You see, number one, to confirm the diagnosis. Be sure that is not other problem. Be sure it is idiopathic nephrotic syndrome, or if it is other problem and needs renal biopsy. Confirm the diagnosis. Number two, like you said, acute event, risk of complications. Number three, educate the patients. Educate the parents. Parents need to understand and counsel them. We know nephrotic syndrome in children, most of the cases are idiopathic. They have good prognosis, respond well, but unfortunately, many of them have frequent relapse. Majority of them, they get relapses. So the parents must be patient, sabr. Your child improve, then relapse again. You treat again, relapse again. So at the end, the prognosis is good. So we need to counsel them. Must have sabr. And then before you go to edema, you need to tell us about the diet. How is the diet? How is the diet?
Oh, okay. For the diet, I think the patient can have a normal protein diet and also adequate calories.
Very good. You need adequate calories and normal protein diet. Don't restrict the protein. The only thing which you may restrict, you don't need to restrict. Most of the time there is no restriction. If it is atypical nephrotic syndrome and you think that it is combination between nephrotic and nephritic, you may have salt restriction. You may have salt restriction. But in the idiopathic nephrotic syndrome, usually there is no restriction. Okay. After that, you start telling about edema. You see, edema is self-limited. Edema is self-limited. We don't need to give a human albumin unless, who will tell me? Unless
It is stated that we can give
unless the patient becomes symptomatic hypovolemia. Either the patient go into severe abdominal pain, symptomatic hypovolemia, or symptomatic edema, like the patient developed massive extravasation, then he developed respiratory distress. We know when we have massive ascites because of edema or pleural effusion, the patient may have respiratory distress. In that case, yes. In that case, we use human albumin. It happened one time with one patient, Fakhri, but it was with another group. Fakhri has nephrotic syndrome and he has symptomatic edema. So we started human albumin for him. But otherwise, albumin is not indicated. And if you give albumin, if you go and read in Nelson, they will tell you albumin should be given with supervision of pediatric nephrologist. Should be given with supervision of pediatric nephrologist. Because the problem, when you give albumin, you may go into hypervolemia. Instead of hypovolemia, you go to hypervolemia. So you may need to give small dose of Lasix after albumin. So it is not easy. So in our hospital, unfortunately, we don't have pediatric nephrologist. So we did ourselves. We give human albumin and we observe it by ourselves. But if you have pediatric nephrologist, the decision of a human albumin should be by the pediatric nephrologist. Okay? Again, diuretics, be careful. Huh? Be careful when you say diuretic, because your patient is hypovolemic. And if you give diuretics, you make the condition worse if he has hypovolemia. Diuretics, again, only if there is symptomatic edema. If there is symptomatic edema and it is preceded by albumin. We give albumin to shift the fluid to the intravascular space, and after that, we give the Lasix. Number two, reduce proteinuria, you need to cancel it. If you are talking about minimal change or steroid responsive nephrotic syndrome, we don't use this medication for proteinuria. Proteinuria, again, self-limited. We give steroids. Yes, we give steroids. Number three, yes, we give steroids. So what is the dose of steroids? What is the dose of prednisolone? Starting dose?
60 milligram per minute.
60 milligram per meter square per
day.
Per day. Okay. So my body surface area is 2.1. How much you will give me? Can you calculate? 126. No. You will kill me. Don't give me 126. Because we give 60 milligram per meter square per day, maximum 80. Maximum 80. We don't go more than 80 milligram for 4 weeks for the first episode. First episode, yes, we give for 4 weeks. After that, we taper we go to 40 milligram per meter square EOD, means alternate daily. So how much you will give me? Calculate. You want to give me 80. You are insisting to kill me. You want to kill me again. We give maximum 60. 40 milligram per meter square EOD, maximum 60. For 4 weeks. For 4 weeks. After that, we taper. We decrease 25% every month. We decrease 25% every month. We decrease 25% every month.
Doctor,
yes?
Can you repeat about the dose?
Repeat about the dose, okay? The initial dose is 60 milligram per meter square per day. Maximum 80. So for someone like me, don't give me 126. Give me 80. Give me 80 only for 4 weeks. After 4 weeks, we change to 40 milligram per meter square EOD, but maximum 60. Don't give me 84. For one person like me, you give me 60.
All right. So, that tells me that the induction is higher than.
Yes. Yes. The induction dose is higher than the tapering dose. After 4 weeks, from 40 milligram per meter square EOD, we decrease 25% every month. Every month we decrease 25%.
25%, isn't it?
Yes, 25% of the dose. For example, if your patient, let's say, make it simple, let's say one patient body surface area is 1 meter square. So you give 60 milligram for 4 weeks. Then, after that, if the patient is in remission, you go to 40 milligram AOD for 4 weeks. Then you taper 30 milligram EOD for 4 weeks. Then 20 milligram AOD for 4 weeks. Then 10 milligram AOD for 4 weeks. Then you can stop.
Okay, it's more clear.
Yes. What is the definition of relapse? If the patient has relapse.
When there is occurring twice, when there's a uric albumin more than 40 and the urine distillate took place for 3 consecutive days.
Yeah, 3 consecutive days. So if you go to the pediatric protocol telling more than or equal to plus. I prefer you don't follow pediatric protocol. Usually, if you see the other references, they will tell you 3 plus or more. So urine protein 3 plus or more for consecutive 3 days. That is the definition of relapse. That is the definition of relapse. If the patient has relapse, then you have to re-induce. You have to re-induce.
With first induction dose.
Induction dose 60 milligram per meter square per day, but it is not for 4 weeks. It is not for 4 weeks. If the patient has relapse, we give 60 milligram per meter square per day until remission. Until remission. What is the definition of remission?
The urine distillate nil trace for 3 consecutive days.
Very good. Very good.
Doctor, how frequently should we check the urine distillate? Is in that case for
every day?
Every day. Okay.
Once every day, yes. In home, once patient discharged, must be every day. If the child is hospitalized, every shift. We have nephrotic chart every shift. Every shift we check.
Okay.
Okay. Yes, carry on.
Yes. For the, so the doctor mentioned about the steroid therapy, and also we need to also reduce the risk of complications that the patient might be having, which is this patient had a hyperlipidemia. We can start patient on statin.
Unusual. Don't mention that in the exam. Keep it at the end. Yeah, maybe in adult nephrotic the approach is different, but in pediatrics, I didn't see in my life. I saw many patients with nephrotic syndrome and UM and HKL. I didn't see anyone who was given statins.
Okay.
Yeah.
And then for the infections, like we need prophylactic for the infections, especially
This is important. This is important.
Patient had abdominal distension, so to prevent patient from having spontaneous bacterial peritonitis, we give the patient a penicillin B antibiotic.
Yes. Okay.
And then we can also suggest patient for the pneumococcal vaccines to prevent patient from
Very good. That's correct. Very good. Very good.
Okay. And then for the thromboembolic events.
No, this one you need to cancel. This one cancel. This one cancel. Maybe in adult nephrotic and internal medicine, yes, but in pediatric, we don't give prophylactic anticoagulant. We need to maintain the volume status. The patient will not go to DVT. I didn't see any patient went to DVT when the volume status is good. We never give prophylactic anticoagulant unless the complication happened already. If DVT happen, if renal vein thrombosis happen already, then you may start. But we don't give it as prophylactic.
Okay.
Okay. Next.
Management, I just simplified. That's management. So that I'm not going into detail into the management.
I see. You are not going deep. Okay. Okay. Any other thing you want to tell us?
And then for the for just now, we can follow the algorithm if the patient have any relapse for nephrotic syndrome, and we need to define if patient is relapse or frequent relapse. So the definition for frequent relapse is patient having 2 or more relapse in 6 months or 4 or more relapse in 1 year duration.
Very good. Yes, correct.
Okay. And then the management for the frequent relapse and also relapse is just the same eventually. However, for the relapse, we need to give 60 milligram per meter square per day prednisone until remission. But for the frequent relapse, we also give 60 and then we taper and then we need to keep the dose at lower dose. We don't stop like we do for the relapse. We need to keep the dose lower for the 6 month duration.
Okay. Okay.
And then that's all for this case.
Okay. Okay. So nephrotic syndrome, you see, usually we don't ask you as medical students, we don't ask you about the doses but nephrotic syndrome is a special case because it is common, very important. So we ask about the doses. Yeah, that's why we need to know what is the definition of steroid dependent. Yeah. There is one condition called steroid dependent. Yes?
There are 2 or more consecutive relapse during surgical steroid therapy tapering or 14 days cessation of surgical therapy.
Sorry, the volume is not clear for me. Can you repeat?
There are 2 consecutive relapse during tapering or 14 days cessation of therapy.
I couldn't. The audio, you know, is not clear. It is not clear.
She said
I think she said right.
Okay.
Mic problem. Yeah.
Okay.
Any other one wants to tell?
Ada tu.
Cakap dia.
Yes, it is relapse on 2 occasions. Relapse on 2 occasions during alternate day steroid therapy or within 2 weeks of a stop of steroid therapy. Relapse on 2 occasions. during alternate day steroid therapy or within 2 weeks of a stop of steroid therapy. That is definition of steroid dependent. How to manage steroid dependent?
Relapse on 2 occasions. How to diagnose it?
How to manage steroid dependent? Okay, how to diagnose? Again, give the definition. Relapse on 2 occasions. Definition of steroid dependent. Relapse on 2 occasions during alternate day steroid therapy or within 2 weeks of a stop of steroid therapy.
We should not taper down the steroid.
To manage patients with steroid dependent, number one, you see whether they have steroid toxicity or they don't have steroid toxicity. If no steroid toxicity, you reinduce. You reinduce with the steroid and taper and keep them on as low as possible steroid dose. Keep them on as low as possible steroid dose. If they have steroid toxicity, then you have to go to cyclophosphamide. Cyclophosphamide. Anyone heard about cyclophosphamide?
Yes.
Yes. What are the side effects of cyclophosphamide?
Leukopenia, alopecia,
Very good. Very good.
Gonadal toxicity.
Very good. Something important, you need to counsel the parentis before you give cyclophosphamide.
Leukopenia.
Something more important, future malignancy. Future malignancy. We know cyclophosphamide is anti-neoplastic medication, but unfortunately one of the side effects is the future malignancy. So, like you said, leukopenia, hemorrhagic cystitis, alopecia, sterility, and future malignancy. These are complications of cyclophosphamide. If the patient has relapse after cyclophosphamide,
Consider steroid agent.
again you see, if no steroid toxicity, you reinduce with steroids. If there is a steroid toxicity, you start cyclosporine. Cyclosporine. What are side effects of cyclosporine? Hypertension, gum hypertrophy, nephrotoxicity, and hirsutism. Hypertension, gum hypertrophy, nephrotoxicity, and hirsutism. Okay. Any other thing you want to tell us?
No, that's it.
Okay, any questions from the others?
Yes, Doctor. I have a question.
Yes.
First, I would like to ask about the renal biopsy. There's one book in Win Pediatrics. It said they include the age under 1 year old for indication for renal biopsy. So is it commonly practiced like that? And my second question, so I forgot my second question. Okay, I think I get back to you.
Okay. The answer to your question, there are different protocols. Some of them they consider the age, yes. Some of them, all of them agree for the 4 indications, which are steroid resistant, gross hematuria, hypertension, abnormal kidney function. So these 4 indications for renal biopsy, everybody agree. Everyone agree. When you talk about the age, yes, what you said is right, and I read it. Yes. There are some references talk about the age, like those less than 1 year, or those more than 8 years, more than 9 years, some say more than 10 years. Yes, because the common age which has good prognosis in nephrotic syndrome usually 2 to 5 years, like that. 2 to 5 years, 2 to 6 years. When you go to the age extremities, the prognosis becomes not good as that age range. So some of them consider, yes, renal biopsy in the age extremities.
what is the reason they do the renal biopsy in the child that 1 year?
What is the reason for?
The renal biopsy in that case.
Because they found that many children in these age extremities, they have atypical nephrotic syndrome. They have another underlying problem. Yeah, so that's why they decided to go straight forward to renal biopsy. And this is what happened with Fakhri. Fakhri, you didn't see him. Fakhri, our patient, was admitted with us. We started steroids. Unfortunately, he was steroid resistant. And Fakhri's age was 11 years. 11 years. So at the end, Fakhri was referred to HTAA for renal biopsy. For renal biopsy.
Okay.
Okay.
Thank you.
Welcome. Any other question? Okay, if no questions, we end our session and see you next class, inshallah.
Thank you, Doctor.
Thank you, Doctor.
Thank you all.
Thank you, Doctor.
Thank you, Doctor.